Welcome to join today's ACRSS talk. My name is Gemma Kim, Program Manager. It is a great pleasure for me to introduce our presenter, Dr. Anita Chan, who is going to talk to us about cervical cancer prevention. Dr. Chen was awarded her medical degree from the University of Hong Kong, completed 2 OBGYN residencies, one at the University of Hong Kong and the second at the State University of New York Upstate Medical University. Dr. Chen is board certified in obstetrics and gynecology in US, United Kingdom, and Hong Kong. She is currently working at Providence Women's Health and serving as our board member. She is also serving as an advisory committee member of Asian Cancer Resource and Support Service. She is dedicated to serve Asian community. In her free time, she enjoys traveling and learning about different cultures and people. She also enjoys hiking and the outdoors. Please welcome Dr. Anita Chan.
Thank you. Good morning, everybody, and thank you, Gemma, for the introduction. So let's have the first slide. Today's talk is actually on prevention of cervical cancer. So why do we talk about cervical cancer? Is it that important? The answer is actually yes. Worldwide, cervical cancer is actually a very important gynecological cancer, but it's not as prevalent in the United States because we did have a very extensive and currently too, a very good screening program to prevent cervical cancer. But still, every year we diagnose more than 10,000 women with cervical cancer. So that's the reason why we need to know how to prevent the cervical cancer. Actually, with the current programs available, cervical cancer is actually a preventable disease. So what I'm going to go over today is to look at the cause for cervical cancer, vaccination, screening program, as well as the treatment of precancer. Next slide. So this is the anatomy of the female reproductive organ. So you can see the fallopian tube, the ovary, the uterus, the cervix, and the vagina. So the cervix actually is situated in the lower portion of the uterus, and its functions actually to hold a pregnancy. That's basically the function of it, is the pregnancy is inside the uterus, and the cervix serve as a place where the pregnancy can be kept intact until the time of delivery, that the cervix actually dilate and the baby is born. The cervix is lined by a layer of cells called epithelium. And if you look at this diagram, you can see that the cervix, there's 2 portions. One portion you can actually see from the outside, and that is, if you put a speculum in, you can see the cervix, which is rounded. And that layer is lined by squamous cell. And then you can see there's a little canal. When you look with a speculum, you can only see a little hole in the middle, and that leads up to the canal. And it's a different kind of cells, it's columnar cells. And later on, I will explain to you why we need to know that the cervix actually has 2 types of cells, because they actually cause 2 types of cancer. And the squamous cell cancer, you can see it, but the cancer arising from the cervical canal, you actually has difficulty looking at it and seeing it. But anyway, you can see that the cervix is lined by a layer of cells called epithelium. And that's where cervical cancer come from. So we are looking at changes of this layer that eventually will turn into cancer. Next slide. So what is the risk factors for cervical cancer? Over the years, we actually initially, when we observed cervical cancer, we found that nuns never developed cervical cancer. So we long suspect that cervical cancer is related to sex. And then people works on different kind of sexually transmitted disease. In fact, herpes was one of those candidates that people has extensive work on, and finally they proved that it's not the case. And they finally found HPV. But we also see that if for individuals with multiple partners or an individual with partner has multiple partners, they actually have more chance of developing precancer or cancer of the cervix. And condom only allow for partial protection. Also, individual who are HIV positive, who is smoking, and who has conditions, medical conditions that cause them to have immunosuppression, or they are taking medicine that causes immunosuppression, they have a higher incidence of progression to cervical cancer. So what actually causes cervical cancer? Next slide. I think I'll talk about these later, but anyway, we found that the cervical cancer do not have any increased risk associated with pregnancy or menopause. They do not change the risk for cervical cancer. Next slide. The real cause of cervical cancer we now found out is related to this virus called human papillomavirus. Human papillomavirus is a DNA virus that is transmitted by direct contact, skin-to-skin contact. And human papillomavirus do not just cause cervical cancer. And in fact, later on, I'll explain to you why we actually vaccinate everybody, not just girls, but we actually vaccinate boys. It's because human papillomavirus do not just cause cervical cancer. It's actually relates to cancer that in the vagina, in the vulva. Vulva is actually the skin outside the vaginal opening. It also can cause cancer in both men and women in the anal area, the oral cavity, the throat, and also it causes penile cancer in men. Next slide. HPV actually, a lot of people thought that HPV is genital warts, and which is not true. Human papillomavirus has over 100 subtypes, and only about 40 are known to infect the genital regions. But only about 15 of them actually is related to cervical cancer. It is extremely, extremely common in sexually active individuals. And in fact, it was found that 75 to 80% of sexually active adults will have acquired at least one subtype before they reach the age of 50. In fact, most sexually active individuals acquire at least one HPV subtype between the age of 15 to 25. And HPV infection has zero symptoms or sign. Now, HPV 6 and 11 causes about 90% of genital warts. And the HPV subtype 16 and 18 cause about 70% of cervical cancer. 31, 33, 45, 52, and 58 actually cause about 20% of cervical cancer, and the rest cause the rest of the cervical cancer, but they are less common. The reason I brought it up is now we actually genotype 16 and 18. And we know that if somebody have persistent HPV 16 or 18, the chance of them getting precancer and cancer of the cervix is much higher. Next slide. So the story about cervical cancer prevention has a real breakthrough after we actually realized that the cause of cervical cancer is this virus, human papillomavirus. And we actually subtype them and know that which subtype actually causes cervical cancer. So I think in 2006, Merck actually start selling this vaccine. They developed this vaccine. It's a very interesting story. Now, if you know about vaccine, you know that we basically inject some virus into your body and teach your body to produce antibody to attack these viruses. So when you're exposed to this virus, then you have an antibody response and try to get rid of it. So used to the typical vaccine is we either are live attenuated, that means they're live vaccine, but they make it not active, or inactivated vaccine. But this HPV vaccine is very interesting. Is actually it utilizes the cell wall of the virus. So the vaccine does not contain the DNA of the virus. It only contains the cell wall of the virus. So I know a lot of parents is like, why do I have to expose my child to a sexually transmitted virus? And the fact is, HPV vaccine do not contain the virus. It only contains the viral cell wall. Initially, when it was introduced, the vaccine actually, there are two, one in Europe, they contain HPV 16 and 18, and the one in America contain HPV 6, 11, 16, and 18. So that means the people who were vaccinated against the original Gardasil vaccine, they are protected against 90% of genital warts and 70% of cervical cancer. But in the recent few years, we come up with a new vaccine called Gardasil 9. And this is the only one available now in the United States. And it is vaccinated against the subtype 6 and 11. That means 90% of genital warts. 16, 18, 31, 33, 42, 52, and 58. That means 90% of cervical cancer. We also found that it's extremely effective. So when people are vaccinated against these, we do not see that the individual actually will be tested positive for any of these subtype. But at this point, we do not know exactly the duration of protection because it has not been followed for that long. But it seems that they are pretty long. And remember, I just said that most people exposed to the virus between the age of 15 to 25. So if you give the vaccine before they're exposed to the virus, they're extremely effective. And so far in the last 15 years since the vaccine has been out, personal experience, I haven't seen anyone who was actually had completed the whole series of Gardasil has ever been tested positive for 16 and 18. So it seems to be extremely effective. Now, so do you need screening after vaccination? The answer is absolutely yes. The reason is because the original Gardasil is only protected you against HPV 16 and 18. So there is about 30% chance you can still develop the precancer and cancer. And even now, the newer Gardasil 9, you still have about 10% of the subtype that you are not protected. So therefore, to protect you against getting cervical cancer, you need screening. Next slide. So how do we give a vaccine? So if we can give you the vaccine before you reach the age of 15, because younger individual, they actually can wage a very good immune response. So therefore, you only need 2 doses, 0 month and 6 months. But if you're age 15 and above, then we give 3 doses. So the first dose, and then we have the booster at 2 months and 6 months. If you're HIV positive, or if you have immunosuppression, then you need the 3-dose regimen. Next slide. So in this country, we now have this vaccination program that vaccinate all, it means all children, whether it's boys or girls. I know initially when the Gardasil was introduced, it was only a vaccination program for girls. But we now learn that we actually should vaccinate boys and girls age 11 to 12. The reason for vaccinating the boys are, number one, boys actually can get HPV infections. And they do and could cause penile cancer, anal cancer, oral cancer, and throat cancer. And number two is if the boys are vaccinated, we can achieve a herd immunity. So they don't have a chance of transmitting the virus to the girls. So that's the reason why now we recommend both boys and girls get the vaccine. And the typical age is 11 to 12. The main reason is this needs to be given before they are sexually active. Because once they're sexually active, they will be exposed to human papillomavirus. And so therefore, the vaccine does not treat the infection. It can only prevent the infection. So you have to give it to people before they're sexually active. But of course, you can actually do catch up. So if you miss the vaccination window, even after somebody is actually active, they're probably not exposed to all subtypes of HPV. So they do and could get some protection. Not perfect, not that 90% that I talk about with the Gardasil 9, but then still you could be protected against whatever subtype that you have not been exposed to. And recently, FDA actually approved the vaccine up to the age of 45. But between the age of 27 to 45 so far, I do not know how good the insurance coverage is because it's not a cheap vaccine. But the other thing also is most individuals in this age group, 27 to 45, they've been exposed to HPV. So you have to kind of balance out the benefit and the risk. The reason why initially it was up to 26 is because the original study was up to the age of 26 on the vaccine, but now they have done extended studies, and so that's why they extend the vaccination age up to age 45. But obviously, if you've been sexually active previously, then the vaccine will not give you as extensive coverage, and you still need screening. Next slide. So what is the side effects? I know that a lot of people has problem with vaccination, and they quoted 100 reasons why they shouldn't. And one of the reasons is long-term side effects. So there's been a lot of reports on conditions like chronic fatigue syndrome, different kind of syndrome that they think is related to the vaccine. But study actually show that the individual who had the vaccine compared with those who never had the vaccine, they have similar, if not, less incidence of all these claimed long-term side effects. So in fact, the only known side effects right now is redness and swelling and tenderness at the injection site. Now, the vaccine is not recommended during pregnancy just because the study actually never been done on pregnant women. However, so far, the registry on the vaccine being inadvertently given during pregnancy, we do not see any effect on the pregnancy itself, on the fetus, or any ill effect during pregnancy. So therefore, if you actually get the vaccine while you're pregnant, the pregnancy is safe. And it is very effective, like I said, against genital warts, 90%, cervical cancer, 90%, also for penile HPV infection, anal cancer, and so on. Now, one thing, it does not prevent other sexually transmitted disease. So it is only effective against HPV infection, okay? And it is much better than doing, just prevention by using condom. Because just think about it, condom only cover the penis. And there are other areas that you can have direct skin-to-skin contact during sex. And so therefore, condom is not effective or not totally effective in preventing HPV infection. And vaccination gives you probably the best protection. Next slide. Now, because I just said that, vaccination is very effective, but then unfortunately our vaccine do not cover for all HPV subtype. So therefore, even if you have the vaccine, you still could develop precancer and cancer of the cervix. So therefore, screening is important. Now, the original development of screening is we found that people before they develop cervical cancer, they develop precancer. So we used to do these pap tests because we found that by collecting cells that actually shed from the cervix, and we look at the cells under the microscope, we can actually find some markers to tell us that, oh, these cells are quite abnormal. So therefore, there is a chance that somebody actually had precancer on the cervix. So what it involved is we have to put a speculum into the vagina so we can see the cervix, and then we collect cells. Now, I remember the good old days. Everybody go for a yearly pap smear. And at that time, we use a plastic spatula and we scrape the cervix and we smear it on a glass slide and we spray some fixing material so that the cells are fixed on the slide. And then we send it for the cytologist to look. And so when we do that little pap smear, we actually collect blood, cervical cells, and a lot of junk together with it. So it's actually a very challenging test for the cytologist to interpret. So used to, pap smear actually is extremely inaccurate. It's only about 50 to 60% accurate in telling you whether there are abnormal cells. And that was the reason why before we actually do yearly pap smear, not because we have to check the cervix so often, but because our pap smear is actually not that accurate. So in order to make sure we don't miss it, we have to do it more frequently so that we won't miss it. But nowadays we have a different technology to do pap smear. And so therefore you will see that later on when I go over the screening test, we found that we do not need to do yearly tests, just like before. So next slide. So what actually can we observe on the cervix? So you can see the diagram, right? We have three pictures there. The first diagram is the normal cervix. Like I told you before, we have the epithelium that covered the cervix, the surface of the cervix. The squamous cell is on the outside. You can see it's layers of cells. And then in the cervical canal is a columnar cells, single layer of cells. Now, 90% of cervical cancer is actually squamous cell. And what we believe nowadays is these squamous cells is exposed to human papillomavirus. And it actually got incorporated into the cervical epithelial cells. For most individuals, about 80%, if they're exposed to the human papillomavirus, their own body immune response is able to get rid of it. And so over the course of about 2 years, these virus will disappear. And in fact, that's the reason why nowadays we try not to screen for very young individuals, because the chances of them being exposed to HPV is very high. And the chance of them eliminating it by their own body response is very high. So therefore, usually within the next 2 years, they are gone. So what's the point of trying to catch these transient infection? But for about 10 to 20% of them, these viruses stay inside the cell and they start causing cellular change. And that goes to the middle diagram. These cells change to a very different shape and form, and we call it dysplasia, and basically means precancer change. Usually this typically takes a duration about 10 to 15 years. And then after this stage, over the next 5 to 10 years, then it will eventually break through the little, you can see the very little thin membrane there. We call it the basement membrane. When it breaks through the basement membrane, it becomes cancer. And once it breaks through the basement membrane, it will have unstopped growth. It can grow out and it can grow in, and then it can spread to other parts of the body. And we call it cancer. The goal of screening is to pick up dysplasia. And it's not just to pick it up. Later on, I'll go over how to treat these. We can actually treat dysplasia. And once we treat dysplasia, we remove this particular focus of precancer change. But of course, we only remove that particular focus. We cannot remove the HPV. So therefore, eventually, some people will and could have persistent HPV. And I'll go over how to treat those later on. Okay, next slide. Okay, so who should be screened? Like I just said, for girls less than the age of 21, because of their own body immune response, most of them, they are exposed to a new type of HPV, but the body can actually get rid of it. So therefore, screening them at such young age is probably not necessary, because the chance of them actually developing cancer is extremely, extremely rare. Also, if we start screening them, then we are faced with a dilemma: do we or do we not treat them? And if we don't treat them, what is the long-term consequence? We don't know. Chances are they don't develop cancer, but they will be extremely, extremely anxious. So therefore, I know that we used to screen everybody, whether they're 15, 16, as long as they're sexually active, we screen them. Now we don't recommend it because it increases anxiety, and we are not going to decrease the total incidence of cancer. Between the age of 21 to 29, we screen them with pap smear every 3 years. Some people over the age of 25, they also do the HPV testing too, but you will actually expect them to be positive. By 30 to 65, we will assume that most people have been exposed to some kind of HPV and they've been able to get rid of it. And these individuals, we can do either pap smear every 3 years. I think nowadays we are leaning more and more towards HPV testing only, or HPV and pap, what we call co-testing. The reason is because pap smear, if we go back, what I just told you about the pap smear is we use a broom or something to recover the cells from the cervix and try to make a fair guess of, okay, this appearance of the cells, what does it mean by the cells that is actually on the cervix? So it's actually really a guessing game. So therefore, we found that pap smear is not as accurate as the HPV testing. So that's the reason why we are moving more towards HPV testing than just doing pap smear. However, the more recent way of doing pap smear is quite different from what it used to be. So I told you that before we used a spatula and kind of scrape the cervix, and now, and then put it on a slide. Now we actually don't do that. We use a broom to basically sweep the cervix a few times. I personally also do one more little thing is I actually have a little brush that go into the cervical canal, because the cervical canal cells are actually not easily recovered by with the usual broom. So I put the brush into the cervical canal and kind of brush the canal. And then we put these brush and broom into a specimen bottle with liquid. And what they do is they use this liquid and spin it. So they can actually spin out the blood cells, the junk, and only get the cells from the cervix. And they put it on the slide, and we call it a thin prep because it's a thin layer of cells. So instead of layers of cells, so the cytologists have a difficulty interpreting the cells. Nowadays, it's a thin layer of cells, so it's much easier to see and much more accurate. So that's the reason why now, even if we do pap smear, we do it every 3 years. The reason why if you do HPV testing, you can space it out to 5 years is because we're actually catching HPV infection before dysplasia or before there's any cellular change. So like I told you before, HPV infection to dysplasia is about 10 to 15 years. So therefore, if we do HPV testing, we actually catch them earlier. And in fact, we are very aggressive nowadays if somebody's tested positive for HPV 16 and 18. Now, after the age of 65, we can stop screening if in the last 10 years, you have at least 3 consecutive normal pap or 2 consecutive normal Pap and HPV. And at least the last one is within the last 5 years. Reason is because if you are, especially if you're HPV negative, the chance of you developing cervical cancer is very remote, the same time sequence. If you are negative on HPV and you only acquired HPV after the age of 65, it actually takes you at least 25 years before you can develop cervical cancer. That means it takes you to the age of 90 to get cervical cancer. Second thing is, we also found that the place where people actually acquired HPV is at this junction called squamous-columnar junction. If you remember the slide on the cervix, you see the canal cells, the columnar cells, and the outer cervix, the squamous cell. The junction between the columnar cells and the squamous cells, we call it squamous-columnar junction. And that's the place where the cells are actively dividing, and that's where the HPV will go into. When you are postmenopausal, that squamous-columnar junction go up to the cervical canal and higher up. Second, the cells are no longer actively dividing. So therefore, even if you acquire a new HPV after the age of 65, it's unlikely to get you infected, and it's unlikely to progress to precancer. Next slide. Now, however, you will need to continue to be screened if you have history of abnormal Pap, especially if you have treatment for precancer or with the cancer of the cervix, vagina, vulva, or anus. That means you have active HPV infection going on, or you're HIV positive. Now, these individuals tend to have progression of cancer. Or if you're immunosuppressed, you have autoimmune disease, or you are on taking immunosuppressive therapy. There's a very special group who are the women who whose mother has taken this medicine called diethylstilbestrol. This is a medicine that was given before 1981, before we realized the impact on the fetus. At that time, we believed that it actually prevent miscarriage, prevent complications, and quite a number of women has taken this during pregnancy. And so the female fetus has been exposed to diethylstilbestrol. And these women has much high incidence of cervical cancer and vaginal cancer. So these women needs to be screened beyond age 65. Next slide. So how about hysterectomy? I know that used to, even after hysterectomy, people still come back yearly for female examination. And they said, well, why don't you do a Pap smear? I said, you don't need it because you don't have a cervix. Because Pap smear is very sensitive in detecting precancer of the cervix. Whereas if you don't have risk factors for vaginal cancer, then doing a Pap smear on the vagina is pretty useless. Actually, vaginal cancer is extremely, extremely rare. In fact, personally, I only have seen 2 cases of vaginal cancer in my last 30-something years of career in being OBGYN. So screening for vaginal cancer is not necessary. If the cervix is removed during the hysterectomy, then you don't actually need screening. However, there's a kind of hysterectomy we call subtotal or supracervical. That means we only take off the uterus and leave the cervix behind. So therefore, you still have the cervix. So you still need Pap smear. Or if the hysterectomy was done for precancer or cancer of the cervix, then yes, you do need screening because you are the one who is actually at risk for developing cervical cancer and also meaning vaginal cancer. Of course, if you've been exposed to diethylstilbestrol when you are inside your mother's womb, then yes, because actually this is the group that actually develop vaginal cancer. Next slide. Now, of course, when the Pap smear result come back, is either normal or abnormal. And nowadays we do HPV testing, of course, is either positive or negative. Now, for some lab, we actually have subtyping on the HPV, and we particularly subtype for 16 and 18 because the two of them combined cause 70% of cervical cancer. The other importance is, especially for HPV 18, there's association of that with adenocarcinoma of cervix. Now, later on, I will discuss a little bit on adenocarcinoma cervix. It is quite, it's a cancer that is quite difficult to diagnose because it is up in the cervical canal. In early stage, patient has no symptoms, you cannot see it. And in fact, in some of the screening tests, we actually missed it, especially if you do pap smear only, especially if you do it in the old-fashioned way using a spatula, because you are unable to get the cells from the cervical canal. So I actually have seen some people do pap smear without doing the endocervical brushing. So in those circumstances, you actually can miss the precancer stage of the cervical canal. So therefore, it is the HPV testing is actually pretty valuable because if you are tested positive for HPV, especially for 18, and also actually I found adenocarcinoma who are positive for HPV 16 too. For those, we actually pursue them. We particularly look for the precancer of the cervical canal. The importance of the pap smear result is it helps us to look for precancer. And we try to distinguish between whether it is a precancer or it is just a transient change on the cervix, and that we can observe. And usually within the next 2 years, they are going to disappear. Next slide. So what are the conditions in which we think that we can observe? When we have the pap smear coming back, it comes back with different kind of terminology. They are very interesting, but it's very, very difficult for most people to understand because we have these funny terminology. But let me just go over them and hopefully you understand, but sometimes it's confusing for most people. Now, the first pap smear result that I talk about is called atypical squamous cells of undetermined significance. What does it actually mean? Is when they look at those cells on the slide, they are seeing these squamous cells, but they don't look exactly normal. But then they cannot tell what they are. I always said that this is a waste paper basket. We throw in all the one that we don't know, and we call it atypical squamous cells. However, in this particular group of pap smear result, actually about 70% actually have precancer, but then less than 1% will progress to cervical cancer. So for younger individual, because the chance of progression to cervical cancer is so low, we usually just repeat the pap smear in a year. But if we have 25 and above, we usually do a reflex HPV testing. If the HPV is positive, that means there is a chance that actually it is a precancer. So we do a procedure called colposcopy. And if the HPV test is negative, then most will just repeat the pap smear in a year or repeat the HPV in 3 years. Because if you are HPV negative, the chances are you're actually never exposed to the HPV. So the atypical squamous cells belongs to something that looks a little abnormal, but they are not precancer. Later on, I will explain to you what colposcopy is. Next slide. However, this is another atypical squamous cells, but it says you cannot exclude high-grade squamous intraepithelial lesion. Now, actually for pap smear, it's very simple. Just remember 2 words, low grade, high grade. High grade means higher chance of precancer. Low grade means lower chance of precancer. And ACRSS is the waste paper basket. But ACRSS H means high grade. As far as I'm concerned, I don't care what the previous word means. As long as they cannot exclude high grade, I treat it like a high grade. Because actually within this group, 33% of them are precancer, and there's about 3% chance of progression to cancer. So we treat them like a high-grade lesion. Next slide. Next slide. So what is low grade? Low grade squamous endothelial lesion. Actually, medical terminology is actually very complicated, but actually very simple. If you break down this word, lesion means abnormal. Squamous means squamous cell. Intra means inside. Epithelial means epithelium. Low grade means less chance. So it is a lower grade kind of abnormal squamous cell inside the epithelium. So if you look at the epithelium that line the cervix, if you have less than a third involved with abnormal cell, we call it low grade. Anything more than a third, we call it high grade. And the reason is because most of the low grade will go away in the next 2 years. And much, much, much less will go away in the next 2 years if you have a high grade lesion. So that's how we distinguish. So very simple. Low grade we watch, high grade we treat. That will be the basic principle. So even with a low grade lesion, actually about 6 to 9% will be high grade actually, but less than 1% will progress to cervical cancer. So actually for young individual, we just repeat the pap smear. And for 25 and above, same thing. If you are HPV positive, we do a colposcopy and biopsy. And if you're negative, we repeat it in 1 year. And we'll see whether you still have the persistent low-grade lesion. There's one thing of caution is any test that we do, they're not 100% accurate. I have seen pap smear, and HPV testing. Pap smear shows low-grade changes, and the HPV, it says HPV positive, but negative for HPV 16. And when I do a colposcopy and biopsy, and the pathologist will stain the cells on P16, which is HPV 16. And in fact, in more than one instance, I actually have seen positive results from the P16 staining. So that means the patient is actually positive for 16, but the assay is negative. So that's why if you have a pap smear that is not agreeing with the HPV testing, I always will like to repeat at least in a year, because then in case the original one was wrong, then your next one, you will pick it up. Next slide. So what is colposcopy? So colposcopy is actually a very nice term for a magnifying glass. So what I'm using here is actually a magnifying glass. So what we do is we put a speculum inside the vagina, and we put 5% acetic acid on the cervix. It's a very nice term for just the household white vinegar. The white vinegar will turn the abnormal cells on the cervix white. And in some circumstances, especially for the high-grade changes, it has certain pattern. We describe it as cobblestone, abnormal vascularization, all these funny terms. It's just that the cells look abnormal. But in order to see it, I use a magnifying glass so that I can actually use this particular instruments that I can actually see the cervix much clearer. And then through this, I do the biopsy on the worst looking area. So therefore, then we can tell, we can send a specimen so the pathologist can actually make it in a slide, and they can actually see the whole thickness of the epithelium. So they can tell me whether it's a low-grade change or a high-grade change. So that's the purpose of the colposcopy biopsy. However, having said that, colposcopy is actually not very accurate. Study actually show that no matter how experienced you are, you could be wrong on the colposcopy. And we have seen more than one instance, it's actually not uncommon, that when I do a colposcope, the cervix looks totally normal. And yet I would just do a few random biopsy and it come back to the precancer. Or I would do a scraping of the cervical canal. And sometimes I choose to do that, although it's not very nice because when I do that, you actually will be cramping quite a bit. But then we actually recover cells high up on the cervical canal. And some of these cells could be abnormal, especially the kind of precancer arising from the cervical canal. So a lot of time we use this tool to help, but still, the more number of biopsies we do, the less likely we're going to miss a lesion. Next slide. So like I said, low grade we watch, high grade we treat, because in most of the high grade lesion on the pap smear, 53% of them are precancer and 70% progress to cervical cancer. So therefore, this is the group that has very high chance of progression to cervical cancer. So therefore, this is the group that we have to watch very carefully and we need to treat. And in fact, unless you're very young, usually between the age of 21 to 24, we typically just do a colposcopy and biopsy. And sometimes we choose to watch. But for older individuals, especially for those who completed the family, means that you have the number of children that you want, we usually want to just do a colposcopy and then treat you at the same time. The reason is because, number one, over half of them are precancer that require treatment. And number two is, unfortunately, our colposcopy and biopsy are not very accurate. So if we actually miss the precancer and decide not to treat, so obviously there's a chance that we actually missed out on treating you before you develop cervical cancer. But however, for women who are very diligent in follow-up, remember I said from precancer to cancer is 5 to 10 years. Unless you're a smoker, unless you're HIV positive, unless you're on immunosuppression. Otherwise, the progression typically actually takes about 10 years. So even if we observe for a short period of time, we're okay because it takes that long to develop cancer. But to be honest, if you have no problem, most of the time I just do the colposcopy and will do the LEEP because the LEEP will allow me to get enough tissue for the pathologist to make a definitive diagnosis. And later on, I will go over the LEEP procedure with you. Next slide. Oh, I have a picture on the LEEP. LEEP is actually called loop excision of the, basically we are excising the abnormal area. And the advantage of the LEEP is we actually remove the lesion. We can send the whole area for the pathologist to look, so they can actually make a final diagnosis of what is on the cervix. They can also tell me whether the margin of the excised portion is involved. That means whether you're completely treated. And it is extremely effective in treating high-grade lesion that involve the squamous cell portion of the cervix. And usually after we do the LEEP procedure, we apply something onto the cervix to stop bleeding. And typically it is Moncel solution. Next slide. So the next kind of slide, a pap smear result we get is called atypical glandular cells of undetermined significance. Now remember I said the cervix consists of two types of epithelium. One type is the squamous cell, and squamous cell carcinoma accounts for about 90% of cervical cancer. But the rest of the 10% of cervical cancer actually arise from the cervical canal. They are the glandular cells. So therefore, if your pap smear shows some atypical glandular cells, then you have to be worrying about the cancer changes on the cervical canal. But in fact, although they said it's atypical glandular cells, but actually a lot of them is actually squamous cells. So we do and always have to do colposcopy to look at the cervix, which is the squamous cell portion. But we also should evaluate the cervical canal. And unfortunately, you cannot see the cervical canal because it's up inside and it's a very narrow canal. So there's no way you can actually look at the cervical canal. So typically we do this procedure called endocervical curettage. That means we put a little curette, go into the cervical canal, and unfortunately, it is a blind procedure. We blindly go through the whole cervical canal and think that we actually can sample the whole cervical canal. It works in some situations, but it's unfortunately it's not extremely accurate because, again, like I said, it is a blind procedure. You keep scraping on the cervical canal and hopefully you recover the cells from these columnar cell layers and be able to tell what is happening. What else gives you glandular cells? Apart from the cervical canal, actually inside the uterus is also lined with endometrium, and endometrium is also glandular cells. And if you actually have precancer or cancer of the endometrial cells, some of these cells can be shed into the cervical canal. So therefore, when you do a pap smear, you'll find atypical glandular cells of undetermined significance. Sometimes the pathologist can actually tell you it favors endometrial cells, and those will give you a little ring. Hey, you probably have a problem. That is especially important in certain individuals, like postmenopausal women. Because after menopause, you're not supposed to shed endometrial cells. Your endometrium should be extremely thin. So you shouldn't shed any endometrial cells. If you do, it's very high risk for endometrial cancer or precancer. The other is if you're over the age of 35, you have abnormal bleeding, irregular cycle, or heavy menstrual bleeding. So there is a possibility you have precancer or cancer change of the endometrium and you shed the cells. So that's why this is the group of pap smear. When we see it, we do everything. We do a colposcopy, we do biopsy, we scrape the canal of the cervix, and we also do an endometrial biopsy. Next slide. Now this is endometrial biopsy. Nobody likes it, but it's actually very effective. What we believe is if you have precancer or cancer change of the endometrium, that means the inner lining of the uterus, then the lining is very thick and the cells are very readily shed. So this is an office procedure. We pass a tiny tubings. It's about 2 millimeters thick. So for most individual, your cervical canal can allow this tube to be passed. You pass it into the uterus and you apply suction pressure. And if you have precancer or cancer change of the cervix, there are a lot of cells inside the endometrial cavity. So despite the fact that the tubings has only a tiny hole, you recover some of the cells there. Now, but originally when it was the pipelle was first introduced and they claimed 90 to 95% accuracy, but in fact it is not. So in circumstances when we are very suspicious, typically I will order a pelvic ultrasound and the ultrasound can tell me the thickness of this lining. And if this thickness is too thick, or the appearance is not very normal. So although the biopsy is negative, I would usually recommend proceeding with the next step, which is the gold standard to evaluate the inside of the uterus, and it's called hysteroscopy. Same thing, medical terminology. Hyst, H-Y-S-T, is actually uterus. Scope, and it means a camera. So we're basically putting a camera inside the uterus. So usually we put people to sleep. It's more like a conscious sedation, make you sleep, and then dilate the cervix, put a camera in, take a good look inside, and basically shave the lining so we can be sure what is going on. Next slide. Squamous cell carcinoma. Now, squamous cell carcinoma of cervix is seldom diagnosed by pap smear because if you do have a cancer, most of the time we can see it. So therefore, if you look at the side, you can actually see that you can see something pretty abnormal looking, and we can tell that it is cancer. But of course, in extremely, extremely rare circumstances, when you have a very, very early cancer, sometimes you could diagnose squamous cell carcinoma on the pap. It's estimated is about 4 out of 100,000 slides that you make such a diagnosis. But typically, if you cannot see it and the slide actually shows squamous cell carcinoma, it's usually a very early stage. My experience is typically these so-called stage 1A1 cervical cancer, we actually pick it up by diagnosing high-grade lesion. And when we do LEAP procedure, we actually found the cancer. Next slide. When there is certain circumstances when we get a pap smear result, which is abnormal, and then we have to think, should we or should we not managing it? For pregnancy, we try to avoid biopsy because the cervix is extremely vascular in pregnancy. So if you try to biopsy the cervix, you're in for trouble because she might not stop bleeding. And also the cells are very difficult to interpret. So we typically defer the biopsy until about 4 weeks after delivery. If we have a high-grade lesion on the pap smear, I will do a colposcope and take a look and see whether it's very suspicious for cervical cancer. Now, if it's a cancer, that's a different thing. Then we do have to do a biopsy because we need to know. But otherwise, we typically defer until at least 4 weeks after delivery before we do the colposcopy and biopsy. For menopause, there's absolutely no change in the management. So we manage exactly the same way like we manage for everybody else. The only problem with menopause is, like I told you before, remember the junction between the squamous cell and the columnar cells go all the way high up in the cervical canal. So a lot of time when we look at a postmenopausal cervix, we don't see anything abnormal. Not because she does not have the abnormal cells, but it's higher up in the cervical canal and you cannot see it. Next slide. Now, so like I explained to you before, you see these 4 slides, 4 pictures. The first picture is normal cells, and on the pap smear, we see these very normal cells, and when we do biopsies, we see everything very normal. And then it goes through changes of the so-called SYN1, SYN2, SYN3. Cervical intraepithelial neoplasia is a pathological diagnosis. It's diagnosed by biopsy. And same thing, neoplasia means abnormal cells. Intra means inside, epithelial means epithelium. So abnormal cervical cells inside the epithelium. They are not cancer. And I repeat, a lot of patients tell me that, oh, I had a cone biopsy done because I have cancer of the cervix, or I have a hysterectomy done because I have cancer of the cervix. And what they actually means is cervical intraepithelial neoplasia, because they see the word neoplasia means cancer cells. And so they thought they have cancer, but it is actually not cancer. The good thing about prevention of cervical cancer is, apart from the vaccination and the screening test, we actually have treatment for precancer. And if we can treat the precancer, the chances are you do not develop cervical cancer. And so, like I said, if you do a biopsy and you have the SIN1, we watch. If you have the SIN2 and SIN3, we actually treat you. And the treatment are a few types. The first one is the traditional one that people do probably in the 60s, 70s, and maybe the early 80s, is cryosurgery. The so-called cryosurgery, cryo means freezing. So they have a liquid nitrogen tank and they connect to a little probe and they put that probe on the cervix and freeze the cervix. The problem with this cryotherapy is you destroy the cells. You hope that you destroy the cells, but you are not sure you destroy the cells. It is more important for younger individuals when you try to preserve as much cervix as possible, but there's no way you can tell whether someone actually have the real intraepithelial neoplasia or whether you actually completely treat it. Then it comes the laser. In the 80s, especially early 80s, it's very popular. The doctor who can do laser are the good doctor because they're so modern. They have the new technology called laser. And with laser, you have to put people under sleep and do it in the operating room because the laser machine is not very safe to be done in the office setting. So, and then they need special technologists who know how to operate the laser machine. And what happened is they use very high energy, high intensity light beam and basically evaporate the cells. And so it can only be done in the operating room setting because you are evaporating cells that actually contain HPV. But of course, at that time, they don't know anything about HPV. So they didn't know that they actually disseminate the HPV in the environment. But the good thing about surgery is they have special filters so they can get rid of the virus. But ever since probably the mid-80s, we start not doing these ablative procedure, but rather we do excision procedure. And that comes the LEAP procedure. Next slide. So with these SIN2 and 3 especially, if you're 25 years old and above, we always try to treat you. Next slide. And the treatment is, like I said, the LEAP procedure. LEAP is called loop electrosurgical excision procedure. And you can see in this slide that we have a loop wire and we connect it to electricity and we just basically scoop out the abnormal area. But of course, we have to map the cervix and make sure you actually get the whole abnormal area. Typically, we give local anesthesia to the cervix first so you can't feel anything, and then we remove the abnormal area. The good thing is we provide sample for confirmation, and what we also ensure that the margins are involved. But I typically explain to patients that sometimes the pathologist said that your margins involved, but most of the time, actually studies show 56% time, your margins are actually not involved because remember this is a metal wire loop that is connected to electricity. So it actually burn on both sides, both on the removed tissue as well as on your cervix. So you actually have an additional 0.07 millimeter margin on your body. So that's the reason why most of them, they're actually completely treated. Next slide. So this is the LEAP machine that I use in the office. It is connected to electricity, but at the back of that Cooper Surgical, there's a big cylinder there. It's actually a filter. We also have a little tubing that we insert into the speculum. So any fume that come out when I burn actually go into the tubing and into the filter. And the tubing and filter are disposable, so they're all disposed of. And when we do that procedure, we always wear N95 mask because we don't want to inhale the HPV. And the N95 mask is different from what you get from the market. The one that we get is actually fitted, so you cannot breathe in air, at the edge of this mask. You always breathe through the mask. Next slide. So that is the lead procedure to treat precancer of the cervix involving the squamous cell. It's actually about 70% effective in prevention of cervical cancer. About 30% of those who are treated with LEAP, they actually have recurrence. They have HPV subtype that are pretty aggressive, and they can recur. And usually with recurrence, if you have completed the family, we will actually recommend hysterectomy, which will be the best way to take away the cervix so you won't have any recurrence. The one thing about the less typical kind of cervical cancer, adenocarcinoma of cervix, which account for 10% of cervical cancer, the precancer stage is called adenocarcinoma in situ. Now, the problem with adenocarcinoma in situ is, number one, it's difficult to diagnose, but number two is it has typical skip lesion. That means you can have one in the lower portion of the cervical canal and one about maybe 2-3 centimeters above in the cervical canal. So therefore, even if you think that you remove one lesion complete with good margin, you might have another focus up there in the cervical canal. So therefore, the treatment is actually different from the squamous carcinoma in situ. We do a cone biopsy if you want to preserve fertility. But then you need to be followed with PAP and HPV and also endocervical scraping every 6 months. And the best treatment is actually hysterectomy. Next slide. Cone biopsy means you actually put someone to sleep and then get a really good cone out of the cervix. And in fact, I normally take more than what is on this diagram. I actually get it almost up to the internal opening. Because like I said, they tend to have skip lesion. So you really have to do a deep cone in order to get the whole area out so you know for sure. And in fact, when I have a suspected adenocarcinoma in situ on either endocervical curettage or cervical biopsy, I do a deep cone first to confirm it is just adenocarcinoma in situ, but not adenocarcinoma, before we proceed with the hysterectomy. Next slide. I think I just said these treatments are extremely effective except for adenocarcinoma in situ, but there's 30% of recurrence, especially if you're positive for HPV 16 and 18. So therefore, long-term follow-up is essential. And most of the time, if you have recurrence, I will recommend hysterectomy. And in fact, what I can see nowadays, people presented with a frank cervical cancer is from those individuals who didn't go for screening, or those individuals who have been treated before but never go back for follow-up. And those are the individuals that I diagnose cervical cancer. I actually haven't seen any cervical cancer from those that come in regularly for pap smear, or even if they have abnormal pap smear, they come in for treatment and then keep coming back for follow-up. Very good. I think this is my last slide, right? Oh, no. Okay, pregnancy. One more. Now, abnormal pap smear and treatment, they do not change your chance of getting pregnant. There's no change in fertility. Now, however, excisional procedure like the LEAP or the cone biopsy does cause increased risk of preterm deliveries. Because remember, the cervix is the door for the uterus. So when you're pregnant, the cervix function as a closed door and keep the pregnancy inside. And the integrity of the cervix depends on how much cervix is there. So if you have removed a portion of the cervix, you remove portion of this integrity. So therefore, there is theoretically a higher chance of it not holding the pregnancy so good. And so studies show a slight increased risk of preterm delivery. But at the end of the day, you have to balance out between the risk of you developing cervical cancer and the subsequent preterm delivery, which we do have other way of decreasing the risk and watching for it. Typically, we suggest that if you get treatment for precancer of the cervix, you wait 3 months after treatment before you attempt pregnancy. Now, this is not something that we know for sure. It is more an expert opinion rather than we have done study and said it's safe. Next slide. Okay, I think that's it. Any questions?
Thank you very much. Thank you so much, Dr. Chen. I deeply appreciate the wonderful presentation you made this morning, and we really appreciate your effort to preventing cancers and saving many lives.